Ramakrishna Hospital for the last 3 years. Today's speakers are Dr. Aarti. She is a general physician and she has done her MD General Medicine, DNB General Medicine, and MRCP UK. She has got MRCP from 3 universities in UK, and she has been an inspiring role model for all the junior doctors here in this hospital. She's going to talk about tackling bloodstream infections made easy. So it seems to be a novel topic, and I'm also eager to listen to her talk. And our second speaker is Dr. Vishnu Kumar Venkateshan. He has done his MS General Surgery, MCH Vascular Surgery, and he is a member of the Royal College of Surgeons of UK. And he has been a consultant vascular and endovascular surgeon in Sri Ramakrishna Hospital. He is also a promising youngster, and he is going to talk about untangling varicose veins. And he'll be joining today, probably in another few minutes. Now I would like to call upon Dr. Aarti to take over the session. Thank you, Dr. Aarti. Dr. Aarti, please.
Madam, I unmute your mic and speak, madam.
Aarti, you are not audible.
Am I audible now, sir?
Yeah. Yes.
Good evening, sir. Thank you for the opportunity given by the marketing team as well as Dean, sir. Today I'm going to talk about bloodstream infections. I thought this topic was more relevant to doctors from various specialties, so I thought let me talk on this topic, because sepsis is the one thing which every doctor from all kind of specialties is going to face. So let's move on to the topic. So bloodstream infections are most commonly caused by these four kinds of organisms. So most common is gram-negative bacilli. Then comes the gram-positive and catheter-related bloodstream infections and candida. So these four are the most common things we encounter, especially in the ICU settings. So going on to the gram-negative bacilli were once the predominant organisms associated with these hospital onset infections, but recently, because of lot of device usages and ICU settings, gram-positive aerobes have also increased. So gram-positive like coagulous negative staph, that is cons, and staphylococcus aureus and enterococci, everything have been recently increasing. So gram-negative bacilli, why it is very important is more than half of the bloodstream infections is caused by the gram-negative bacilli, and the thing is, sepsis with a gram-negative organism with a shock has a mortality rate of about 12 to 38%. Even in a good setting like a multi-specialty setting, it has a high mortality rate. And there is also the problem of multi-drug resistance emerging among all these organisms. And the important thing for us is the mortality can be prevented with a timely and appropriate antibiotic therapy. So that's why it is very important to discuss this. The spectrum of bacteria will depend upon many factors. Important thing is prior health care exposure. For example, patient hospitalized in the last 3 months, and also on the anatomical source of infection. For example, UTI is different from URI. So, Pseudomonas is the most common thing in hospital acquired infections, and in community acquired, E. coli is the most common. So clinical manifestations of this usually starts with fever, and rigors can be indicative of bacteremia, and septic shock. The patients presenting with shock itself can be 25% of the infected patients. So focal symptoms can be there, but in patients who are immunosuppressed, who are neutropenic, and catheter-related bloodstream infections, usually they won't have any focal symptoms, and it becomes a diagnostic challenge. So the diagnosis, as everyone knows, the gold standard is the culture. So at least two samples, preferably three, should be taken from separate venipuncture sites, and contamination should be strictly avoided. The venipuncture site should be effectively disinfected, and the culture collection should not be done through previously existing lines, and minimum of 20 ml sample should be collected, and 10 ml in an aerobic bottle and 10 ml in an anaerobic bottle. So mostly nowadays all the laboratories having instrument based monitoring for blood cultures. So a 5-day incubation period will give most of the pathogens, but most common pathogens are detected in 48 hours. Some organisms like fungi may require additional period of incubation. So, what are all the organisms which are clinically significant if present? So, Staph aureus, Streptococcus pneumoniae, Group A Streptococcus, Enterobacteriaceae, Haemophilus, Candida, Pseudomonas. If these things are present, so it should definitely be taken as clinically significant, and it should not be dismissed as a contaminant. Other bacteria like Enterococci, Viridum streptococci, cons, Corynebacterium, these things can be a contaminant also, so it should be correlated clinically. So management for this patients presenting with sepsis, an initial blood culture they won't give immediately, so they'll just inform you it is a gram negative organism. So when you get a growth as gram negative organism and clinically strongly suspecting septic shock, you have to start urgent empirical antibiotics, and ideally it should be started within 1 hour of the patient arriving in the ICU. That is the ideal sepsis guidelines. And the patient, the choice of the empirical antibiotics depends upon the many factors: patient's comorbidities, recent hospitalization, the clinical syndrome, respiratory syndrome, or a UTI syndrome. So all things should be considered when selecting the empirical antibiotic. One more thing is to consider is whether we have to cover Pseudomonas aeruginosa and multi-drug resistant organisms. So patients presenting without sepsis or septic shock, so only whether we have to decide patient has recent healthcare exposure or not. So if there is no recent healthcare exposure, only a single broad spectrum antibiotic is enough, and anti-pseudomonal activity is not necessary. In immunosuppressed patients or patients with a previous healthcare exposure, then a single broad spectrum covering a pseudomonas agent is indicated. Patient with sepsis and septic shock, we have to use a combination therapy. Patients with immunosuppression and have risk factors of pseudomonas like diabetes or any other immunosuppression risk factors, empirical therapy itself should have a two anti-pseudomonal agents. So two things means anti-pseudomonal beta-lactam as well as anti-pseudomonal aminoglycoside. Both should be there in the empirical therapy. Without any risk factors for resistant organisms, then we can treat with a single anti-pseudomonal agent. So this is the flow chart for gram-negative bacilli sepsis. So first, if there is gram-negative rods reported from the blood culture, you have to see whether the patient is in sepsis or septic shock. That is decided by the clinical parameters, lactate, procalcitonin, etc. So if any features of sepsis is present, you have to see whether the patient is immunosuppressed, patient has previous healthcare exposure, infection with pseudomonas in the past, or hospital prevalence or community prevalence of gram negative is high. Then we have to combine two anti-pseudomonal agents. So anti-pseudomonal beta lactams are ceftazidime, piperazine tazobactam, imipenem, meropenem, doripenem, etc. plus amino aminoglycoside with anti-pseudomonal activities, tobramycin, amikacin, and gentamicin. So this is the algorithm for patients with a septic shock and risk factors. Septic shock and without risk factors, patient will be having only one anti-pseudomonal agent. No septic shock and no risk factors, then patient can have any broad spectrum antibiotic, and anti-pseudomonal coverage is not necessary. So this is the empirical therapy, and it should be narrowed down after 48 to 72 hours once the culture reports are available. So coming to tapering the therapy, narrowing the therapy is very important, except in cases with ESBL producers and AMC resistance that they will report in the culture. If it is ESBL or AMC resistance, then we have to continue with the combination extended spectrum antibiotics. If it is not there, then we can narrow single antibiotic according to the culture sensitivity. And duration of antibiotics, only 7 days usually it is recommended. Only 7 days is recommended unless if the source control is achieved and appropriate response is there, then only 7 days is recommended rather than 14 days for gram negative. So if the patient is showing clinical improvement, then we can switch on to oral agents if the agents have a high bioavailability. So this is about the gram negative bacteria. Next, moving on to the gram positive bacteria. So gram positive, we know mostly MRSA and cons, that is coagulase negative staphylococcus is the most common. So history should be focusing on any source, because these kind of gram positive bacteria always mostly have a source like a bone infection or a joint or a skeletal abscess, epidural abscess. So these kind of focal collections can be there. So history should focus on that. And also they are prone for metastatic abscesses. So we have to see any endocarditis features is there. That also should be ruled out in history and examination. And in examination also you have to search for clinical stigmata of endocarditis. And all patients having gram positive bacteria on blood culture, which later reports as staph aureus, should undergo an echo to rule out any vegetations. So initially we won't have the organism, so only a gram positive will be reported. So during that time we have to cover MRSA definitely. So the choice of antibiotic is a single antibiotic. It is not a combination like gram negative. So single antibiotic with the vancomycin is the initial therapy. Daptomycin is an alternative for vancomycin, can equally effective. After the culture reports as MSSA, then we have to change to beta-lactam antibiotic, even though vancomycin is sensitive, because vancomycin is less effective for the treatment of Staphylococcus aureus than beta-lactam. So beta-lactam efficacy is more compared to vancomycin. So if there is any sensitivity to cefazolin or cloxacillin antibiotics, we have to change to that, cut down the vancomycin. Uh, there is no role for combination therapy of anti-staphylococcal antibiotics. As told previously, only gram negatives require combinations. Usually, for endocarditis or a prosthetic valve endocarditis, they will use combination with rifampicin or an aminoglycoside. But in other settings, it is not required. Only vancomycin or a penicillin is sufficient. Coming to the duration, we saw that in gram negative, the duration is recommended 7 days. But in gram positive case, even with the removable focus, the duration of therapy should be 14 days parenteral only. It cannot be converted to Ideally, it should not be converted to oral. So if the culture reports specifically as MRSA, then we can continue the monotherapy with vancomycin, or if daptomycin was initiated previously, we can continue with the same monotherapy. But in case of MRSA, documented clearance of bacteremia should be done. So after 48 to 72 hours, culture should be repeated, and if the culture is negative, we can continue with the monotherapy. So that is called favorable initial response. So patient is afebrile and the sepsis features are improving, then we can continue with the vancomycin monotherapy. But if there is an unfavorable initial response, patient does not show clinical improvement, or if the culture is again growing the organism, then we have to search for any occult focus or abscesses like epidural or vertebral osteomyelitis or a joint abscesses or any occult focus. We have to search and drain it. But after searching also, if you are not able to find any removable focus, then we have to modify the antibiotic. So when we are modifying, initially if we have initiated vancomycin, we can try changing to daptomycin. But still, if the patient has risk factors like a severe critical illness, better to go for combination therapy. So combination therapy is recommended with daptomycin and ceftaroline, which is the fifth generation cephalosporin. So in these sick cases, we have to continue the combination therapy till cultures become negative and clinical improvement is there. So daptomycin, one disadvantage is if the primary source is pneumonia, it cannot be used because lung penetration is very poor for daptomycin. So next move, hello. Now moving on to catheter-related bloodstream infections. So as we all know, the major issue comes with the patients on hemodialysis using a vascular access catheter, or ICU patients having a central venous lines. So in these settings, because the contaminant is usually from the skin commensals, the gram positive is more common. But gram negative and fungi can also occur, especially in patients with immunosuppression. Polymicrobial infections can also happen. Why this happens is the outside of the catheter can also be a path for the bacteria entering in, or some bacteria form biofilm inside the catheter also. So biofilm containing organisms are very difficult to treat catheter related infections. So usually patients with a catheter having fever and chills, we suspect CRBSI, and most of them won't have any exit site infection like an abscess or anything. Exit site redness or abscess need not be present in every patient. And sometimes only they'll present with a septic shock, altered mental status, or hypotension, or any vague signs can be there. So diagnosis is ideally one sample should be taken from the suspected infected line and one should be taken from a peripheral line, or two samples can be taken from the peripheral vein also. But if peripheral veins are not available, then the catheter sample itself can be taken 10 to 15 minutes apart. So whether to remove the catheter, that is the major question in CRBSI, and what antibiotics to initiate. That is the two questions that will rise. So this depends upon the clinical severity. So patients with severe sepsis or septic shock are hemodynamically unstable, and patients with features of metastatic infections like other organ abscesses or exit site oozing of pus. So if these things are there, then empirical broad spectrum antibiotics should be started even in the emergency department before transferring to the ICU. So you are giving the initial antibiotic therapy and fluid resuscitation and everything, and seeing whether the shock is improving. If the shock is not improving, immediate removal of the infected catheter rather than salvage or exchange over guide wire is suggested. So, but if the patient is improving, the shock is improving, the lactate parameters are decreasing, we can wait for removing the catheter. especially in patients who are on dialysis, who require emergency dialysis, and the patients who have no other vascular access. Catheter removal can be delayed for 48 to 72 hours and see whether the clinical response is there. So empirical antibiotic here should cover both Pseudomonas as well as uh, gram-positive organisms. So vancomycin plus ceftazidime is the first line agents recommended. In case the patient is having allergy to vancomycin, daptomycin can be used, or if there is a allergy to cephalosporin, aminoglycoside like gentamicin or tobramycin can be used. But there should be a combination of both gram-positive and gram-negative coverage. One more thing is antibiotic log therapy. If you are planning to salvage the catheter, antibiotic log therapy should be used, which is this antibiotic solutions can be stock solutions can be made with this given dose. For example, vancomycin 1 gram in 100 ml. So this is the stock solution which should be inserted into the catheter and left for a few hours. So this should be repeated frequently. So this is the antibiotic log therapy. So after the cultures come, it is similar to the previous things, only gram negative and gram positive already what we discussed. So accordingly we have to modify. So mostly with intravenous antibiotics and antibiotic log therapy, patient will improve, and most of them will not require catheter removal. But after 48 hours of therapy, if they are still not well and uh, still in significant sepsis, then we have to remove the catheter. That is recommended. One more thing is Staphylococcus aureus, Pseudomonas, and Candida. These are difficult to clear organism because of the biofilm formation. So, if these organisms are detected, it is better to replace the catheter over a guide wire because or removal itself. If any other vascular access is available, it is better to remove. And till the patient is having a clearance of bacteremia through culture, a new catheter should not be placed. So, for example, dialysis catheter, it should be placed only after the blood cultures become negative. So, yeah, for all the patients, blood culture should be repeated 1 week after the antibiotic therapy to confirm whether the bacteremia has cleared. So this is the catheter-related infections. So lastly, we are going to see the candidemia. So candidemia means candida is grown from the blood culture. So invasive candidiasis means any kind of deep-seated candida infection, systemic candida infection is called invasive candidiasis. Candidemia is the manifestation of a can be a manifestation of an invasive candidiasis. So candida should never be taken as a contaminant, and it should always be treated as an pathogen and should be treated. So it can be a part of a disseminated candidiasis or a deep-seated organ candidiasis like a GI candidiasis, and it can be a part of the catheter-related infection also. It is an important nosocomial pathogen, especially in the ICUs, and non-albicans species is very important because these days half of the candida infections are due to the non-albican species, and this glabrata, parapsilosis, tropicalis, cruzi, these things are um, uh, increasing in numbers, as well as they are all very treatment resistant. Example, cruzi is inherently fluconazole resistant, and glabrata is becoming both fluconazole and voriconazole resistant, and increasing in echinocandin resistance is also being seen. So patients in ICU and immunosuppressed patients are at the greatest risk for this candida infections. The gastrointestinal tract usually acts as a mucosal barrier, but whenever the patient is having uh, immunosuppression, this normal bowel microbiota, which is having the candida, will overgrow, and it will enter into the lymphatics and into the bloodstream. And patients on chemotherapy also, this intestinal mucosa is disrupted, and yeah, the candida enters the bloodstream. So clinical manifestations is not different from bacteria. So any fever or severe sepsis can be there, and a specific feature is if the candida is detected in blood culture, definitely we have to do an ophthalmic examination, and definitely we have to send for echo, because endophthalmitis and endocarditis can occur as a part of the metastatic infection. So there is a characteristic chorioretinitis which happens in the candida infection. So the gold standard is, as usual, culture, fungal culture growing candida, but especially in invasive candidiasis with a deep-seated candidiasis like intra-abdominal candidiasis, we can't expect the culture to be positive. So in those cases, beta D glucan is a cell wall. It's present in the cell wall of the candida, and it can be detected in the blood by certain assays. So that can be used for adjunctive evidence. But if there is any abscess or any tissue involvement, biopsy and culture is the gold standard. But this beta D glucan is not specific for candida. It can be seen in other fungal infection also. So, coming to the antifungal therapy should be individualized. For example, non-neutropenic patients and the neutropenic patients. Non-neutropenic patients, preferably we have to use an echinocandin like caspofungin, but fluconazole and amphotericin B can be used if there is cost issues and everything. Neutropenic patients, definitely we have to use an echinocandin, because already the patient would have been exposed to fluconazole previously also. So fluconazoles, azoles develop resistance very easily, and it should not be used for neutropenic patients with fungal sepsis. The patients who have who become clinically stable, they can be transitioned to oral fluconazole after few days. And as I told, ophthalmologic examination for everyone, it should be done. And whether to remove the central venous catheter for candida. Patient with non-neutropenic patients, definitely the catheter should be removed, because the catheter is the source of infection for them. But for neutropenic patients, usually the source is from the inherent microbiota. So catheter removal is not going to help. So catheter will be more necessary for that patient. So catheter is retained for them. For Candida also, like Staphylococcus, blood culture should be repeated frequently, and clearance should be documented. And endocarditis should be ruled out if there is persistent positive blood culture. Duration of therapy for non-neutropenic patients, we can complete within 2 weeks after the patient becomes better or the culture becomes negative. For neutropenic patients, we have to continue till the absolute neutrophil count becomes more than 500. So there is no specific time for neutropenic patients. And metastatic foci, patients with endocarditis endophthalmitis also require longer duration of therapy. So yeah, for whom to use the empirical antifungals in neutropenic patients? In neutropenic patients, definitely any empirical antifungal like fluconazole or voriconazole should be given. For non-neutropenic patients, uh, uh, for example, you are suspecting sepsis, you are giving all the broad spectrum antibiotics, but still there is no response, and you are suspecting a fungal sepsis, then whether giving empirical antifungal is useful is uncertain. So you have to use the surrogate markers like beta D glucan. If the patient is affordable, better to use a surrogate marker to decide on empirical antifungals. So that's it about the bloodstream infections. So we have seen the gram negative, gram positive, and catheter related infections and candida. Mainly we have focused on the management guidelines. So thank you. Any questions? Any questions, sir?
Thank you, Dr. Aarti, for your excellent presentation.
Thank you, sir.
And I think with great difficulty, Dr. Aarti has spoken in this webinar.
Thank you, sir.
And on behalf of the management, I thank Dr. Aarti for that. And any questions can be directed to so that we can relieve her of from the webinar. Questions can be asked to Dr. Aarti.
Sir, I'm Dr. Jamblingam.
Yes,
On
sir.
behalf of Medicine Department, I really congratulate Dr. Arti, our junior
Thank you, sir.
consultant,
Thank
for
you, sir. Good
her
evening, sir.
first speech. And I think many more speeches will be given by her in future.
Maiden speech.
Sure,
Maiden speech, yeah.
sure, sir. Thank you, sir.
Thank you.
If there are no questions, then I'll invite Dr. Vishnu Kumar Venkatesan for his lecture on untangling varicose veins. Dr. Vishnu, please.
Good evening, sir. Thank you for the opportunity, sir. I hope I'm audible to everyone.
Yeah, audible.
Yes, thank you. Yeah. So today I'm going to be briefly talking about modern management of varicose veins per se. So what are varicose veins? Basically, a spectrum of chronic venous disorders which comprise different ranges from varicose veins to edema to skin ulceration to lipodermatosclerosis. So chronic venous insufficiency, it affects almost 10 to 20% of the population of the Western world. We don't have data for the Indian one, but it is around the same. And it is less common in Asian population. Incidence is in India is around 5%. And the male to female preponderance is around 1:2. But generally over here, we see more of males presenting with varicose veins. This is primarily because women don't come often to the clinic unless there's a much more severe form of disease. And of these, skin changes or advanced forms of disease are seen in up to 6.2% of the patients, and venous ulceration seen in 1% of the patients. So by definition, any varicose veins is any dilated veins, subcutaneous dilated veins, which are greater than 3 millimeters in diameter. It could be a superficial vein, a tributary, or a non-saphenous leg vein, and they can either be tortuous or tubular. Now, the problem with chronic venous insufficiency, it's primarily because of its morbidity. Because of this, people are not able to go to their work because of the discomfort. It causes a financial burden on the family. It is loss of quality of life, plus loss of productive work hours. Going on to the etiopathogenesis, basically, the etiopathogenesis of varicose vein is actually not very clear. There have been a lot of theories. One is genetic predisposition. Studies have shown that when both parents are affected with varicose veins, there is a 90% risk factor that the offspring might be affected with varicose veins as well. And if one person is affected, there's a 60% chance of a female child having varicose vein, or a 20% chance of the male child having varicose vein. And they are found to have an autosomal dominant trait. And along with these, they are also prevalent in other forms of connective tissue disorders, including Ehlers-Danlos type 4, KT or PW syndrome. And also, genes with hemochromatosis and factor 13 deficiency have also been shown to be associated with increased incidence of venous ulcer. Now, what is the actual etiopathogenesis? Basically, it's stagnation of blood in the lower limbs. It's basically due to the dysfunction of valves in the superficial veins, which allows retrograde flow of blood back into the leg. Now, the valve failure can either be primary or secondary to phlebitis, vein wall injury, or due to high venous pressure or hormonal effects. Is everybody able to see my slides?
Yes, sir. We can see it, sir. Please.
All right, sir. Thank you, sir. Thanks. Yeah, I'm sorry. Yeah. Now, the failures of these valves, either at the saphenofemoral junction or the saphenopopliteal junction, it allows high pressure blood to re-enter back into the superficial system, causing all the problems related to varicose veins. Now, this reflux or high pressure can also be due to incompetent perforators, and this can cause secondary failure of the superficial vein valves. As in, the patient can start off with perforator incompetence, and because of repeated reflux of blood, they can cause primary valve failure in the saphenofemoral or saphenopopliteal junction. And the dysfunction of calf muscle pump can also lead to stasis and cause severe reflux. Now, what are the risk factors involving varicose veins? Again, these are varied. It could be a family history of varicose veins, obesity, multiple pregnancies, history of phlebitis, prolonged standing, again, which is commonly associated with varicose veins, and past history of DVT, maternal family history of varicose veins, or poor physical activity are also associated with increased incidence of venous ulceration. Now, basically, venous insufficiency, again, can be classified into primary and secondary. Now, primary is basically a degenerative kind of disease. It's only reflux. The intima of the vein is retained. There is no damage to the vein wall per se, and the valves are the only problematic in these patients. And these patients sort of tend to do well if you operate early on them before complications arise. And they usually comprise of the more milder forms of varicose veins. Now, the secondary varicose veins, these are varicose veins which are caused due to damage to the vein wall per se. This can either be post-thrombotic secondary to DVT. The intima of the vein wall is destroyed, the valves are destroyed. There is deep venous reflex as well. And these patients, they can also be treated with selective patients doing well with surgery, but they require a more comprehensive care with regards to treating both the deep venous reflex as well as the superficial venous reflex. So I'm going to stick primarily to the primary varicose veins over here. Now, what are the clinical manifestations? The majority of the patients with varicose veins are asymptomatic. Symptoms attributed to varicose veins include aching, heaviness, swelling, tiredness, restless legs, feeling like the legs are being dragged behind. There can be cramps or itching. But the thing with this varicose veins is these similar symptoms can be present in 50% of the normal population also. So it's a very diverse set of symptoms. Now, just a quick refresher on the anatomy. So basically, the normal way the blood flows in the leg is there are superficial veins which take the blood and drain them into the deep veins. And they drain them into certain areas with two main valves, which is the saphenofemoral junction and the saphenopopliteal junction, along with a lot of perforator veins which connect both the superficial and venous system. Failure of any one of these valves can result in reflux of blood back into the superficial system, which can result in varicose veins. Now, like I told before, venous reflux, so normally, if you see the picture on the left, the blood is supposed to flow upward and it is trying to flow downwards, the valve closes. This is normal. But when there is valve failure or the vein wall becomes dilated, the valve does not close properly and the blood tends to reflux down. And this forms a vicious cycle actually. When the blood reflux is down, the vein becomes dilated and the valve failure becomes worsened. So it's like a vicious cycle which further worsens the varicose veins. Now, what happens? How does the causative effects of varicose veins happen? Basically, this starts off with the reflux, which increases the hydrostatic pressure in the leg. Now, all this causes stasis in the leg and venous distension. The stasis and venous distension in the vein causes endothelial activation inside the blood vessel, and which causes leukocyte extravasation, and it affects all these macromolecular proteins, increased tumor growth factor and platelet-derived growth factor, and it causes chronic dermal inflammation because of collagen alteration. Now, this is what results in ulceration finally. Now, there has always been a debate with whether the valve was the primary cause of varicose veins or whether the vein wall was the primary cause of varicose veins. So the infinitesimal question is whether chicken came first or the egg came first. But now recent studies have shown that the structural and functional vein wall changes precede valve damage. And these can be due to matrix metalloproteinase induced in patients who even have primary varicose veins. Now, how do we classify varicose veins? We have a fairly universal classification system called as the CEAP classification system, where the CEAP stand for different things. Now, the C is basically the different grades of varicose veins, starting from C0, which is no varicose vein. C1 include reticular veins or spider veins. C2 is what we see as general varicose veins. C3 is basically varicose veins along with edema of the leg. And C4 is again, along with edema, they have lipodermatosclerosis, pigmentation or eczema. C5 is a healed ulcer along with varicose vein, and C6 is an active ulcer.
Sir, sorry for the disturbance, sir. Sir, your slide is not moving, sir.
Which slide is it currently on?
Sir, etiopathogenesis, it is stuck, sir.
That's okay. 1 second. Is it moving now?
Now it is going, sir.
So I'll leave it like this. Everybody
Okay,
can see it like this now.
Okay, sir.
Yeah, leave it like this. It's fine. Yeah. Now, this is an example of C1 varicose veins. It's basically called the telangiectasias or reticular veins. These are the most common type of varicose veins that you see in majority of the patients, very commonly in post-pregnancy women. Now, this is an example of C2 varicose veins along with a little bit of edema as well, where you can see these dilated tortuous veins along the medial aspect of the leg. And this is what you see as C4 level of varicose veins, where you see changes in the skin and subcutaneous tissue with lipodermatosclerosis and atrophy blanchi. This is an active ulcer. So this will be a C6 varicose vein. Now, we covered the C part of the classification. Now, going on to the E, which is the etiological classification. It can either be EC, which means it's congenital, which commonly is Klippel-Trenaunay syndrome. EP is primary varicose vein. ES is secondary cause, so secondary to either DVT or trauma. And EN is basically no causes identified. Moving on to A, which is basically the anatomic. It can either be AS, which is superficial, AD or deep, or AP or perforata. And finally, the P is the pathophysiological classification, where the PR is reflux disease, PO is obstructive disease. PR and O is both reflux and obstruction, and PN is no pathology identified. Now, the idea of this classification, it helps us tailor a treatment plan, which will address the patient's problem individually. Now, moving on to the treatment, I'll just start off with the medical management intervention because this is primarily comprised of compression therapy. Now, any form of varicose veins treatment, the compression therapy is the denominator. It is vital for almost every type of modern intervention, bar a few. Now, compression therapy is generally given for CAP classes 2 to 6. And it is a graded compression. That is very important. It is a graded compression. And normally we use class 2, which is around 30 to 40 millimeters of mercury. The only problem with compression therapy is compliance issue. The patient does not wear it. Now, how does it work? So the exact mechanism is actually not known very clearly. But there have been a lot of theories. They facilitate ulcer healing and prevent recurrence. How they work is basically they improve skin and subcutaneous microhemodynamics. And they encourage movement of fluid into the lymphatics, and they improve cutaneous and subcutaneous metabolism due to enhanced diffusion of oxygen and nutrients, and they promote ulcer healing. Now, along with this, there have been TNF levels has been shown to reduce in patients with compression, and these are cytokines which are actually involved in tissue damage. So, thereby by compression, ulcer healing is seen because when these factors drop, you can actually see ulcer healing. Now, there are different forms of compression therapy. Most commonly used is stockings. There are also Una-paste boots, which are rarely used these days, or compressive bandages in many forms, which can be include Velcro dressing or arrow wraps or even inflatable dressings. No form of compression is actually superior to other. Compliance is the most important thing. You can prescribe 100 different types of compression. If the patient doesn't wear them, it is not going to be useful to the patient. So we have to find out the patient is able to wear them or not, and then prescribe them the appropriate one. Now, just a small word on drugs. I mean, these are widely used, but they are not actually, I wouldn't say not very effective, but they're not a primary treatment modality. It can be used as an adjunctive treatment modality. They have been shown to reduce venous edema and ulceration. Main drugs which are used are calcium dobicelate and naftazone. They reduce the cramping caused by varicose veins. And recently, micronized purified flavonoid traction, or more commonly the Daflon drug, they have been shown to basically relieve the same symptoms, but I would keep them as an adjuvant treatment, especially in patients with venous ulceration. While they still need compression therapy or a primary intervention along with Daflon can benefit the patient. So when to intervene? Now again, going back to the C0, the intervention is very clear in this. C0, C1, we don't do anything much. C2 varicose vein, if they are symptomatic, as in if they present with pain, we can intervene. And C3 edema, again, now the indication of intervention becomes more clearer. In C3 cases, we can actually intervene in order to prevent worsening. And cases of C4, C5, C6, where you have skin changes or ulceration, is a very definite indication of treating these varicose veins. So basically, changes in skin and subcutaneous tissue, a healed ulcer or active ulcer, thrombophlebitis, active bleeding are all definite interventions to treat varicose veins. Now, telangiectasias or reticular veins, they are not really indications for intervention unless purely for cosmetic reasons can be intervened with sclerotherapy. Now, just a word of note, secondary varicose veins, like how you see in this picture, which is basically sequelae of post-thrombotic sequelae secondary to DVT, which is very important that we do not primarily intervene to do reflux treatment or any form of endovascular, radiovascular ablation in these patients, because they tend to worsen or they can have recurrence of thrombotic complications. So don't have a primary intervention modality in these patients. These patients are primarily managed more conservatively, or they need a more comprehensive plan which involves treating the deep venous reflux first before going on to the superficial venous reflux. Now, all these patients, proper venous Doppler is a gold standard. It is very, very important to identify what level the disease is, whether it's superficial, deep, the perforator veins, and precise mapping of abnormal pathways, identifying multiple sources of reflux. It does not mean that the patient only has saphenofemoral reflux. They can also have an accessory saphenous vein, which can also be refluxing, or a saphenopopliteal reflux. So identifying all these sources of reflux and accurate documentation, all of this is what we call as vein mapping. And once we have a proper vein mapping, implementing a treatment plan becomes very easy. So generally what we suggest is, even though we get a Doppler from outside, it is better we do a proper scan before surgery to make sure we ourselves document all sources of reflux along with different perforators or different axial refluxes, and make sure there is no deep venous pathology in these patients before intervening. Now, what we see in this picture is a classical picture called a saphenous eye. It's basically the great saphenous vein inside the saphenous sheath. It looks like a knife. And we follow this vein all from the leg all the way to the junction where we map the entire vein. Now, what are the intervention modalities available to us? It can either be open surgery, it can be endovenous ablations, it can be sclerotherapy or glue injection, or multiple newer modalities. Let me start off with surgery. Basically, surgery was the gold standard for treatment of varicose veins. The indications include axial vein reflux with symptoms, C3 to C6 clinical disease, or mild deep venous reflux with superficial vein reflux. And the primary principle of surgery, or even any form of endovascular treatment, is you have to treat the highest point of reflux. So if the patient has both SP and SF reflux, you have to treat the SF reflux also. If you treat only the SP, they're going to recur again. And the GSV stripping can only be done just up to the below knee segment, not below that. And phlebectomy and sclerotherapy can be reserved for smaller below knee veins. I'm just going to skip these slides because this now the high flush ligation or the Trendelenburg procedure is what we see over here. You can see the superficial vein entering into the deep femoral vein, the saphenous opening. Now, what is important for the success of any surgical modality is this flush ligation. We actually should visualize the femoral vein before actually ligating the saphenous vein, and make sure we ligate all the tributaries around it in order to give the highest chance of preventing recurrence to any of these patients. And stripping of the vein, the passage of the stripper can either be top down or bottom up, but the stripping usually we limit it to the thigh segment and maybe up till the knee segment, not below that. And it can either be above down or inverted stripping. Now, again, in the era of endovenous treatment, current indications for surgery include very, very superficial veins where a tumescent can't be given and the risk of thermal injury to skin is there. Very, very large size veins. Again, this is very unique to the Indian population where people present very late with grossly dilated veins which are more than 2.5 centimeters in diameter. Very tortuous veins. Recent history of thrombophlebitis. Acute thrombosis in the GSV. Cost again and physician training. Now, this is the thing I've been telling you about, where you can actually see the common femoral vein being identified and going all the way to do a flush ligation. And stripping, GSV stripping basically removes all the thigh perforator segment and is restricted till the below knee segment. Now, what are the drawbacks of open surgery? Basically, again, it's an incision-based surgery, so there are wound complications can occur. There is increase in delay to return to work, and scarring is a problem. But the most glaring drawback or this thing is recurrence due to neovascularization. Studies have shown that open surgery or flush ligation, because of opening or skin tissue scarring over there, can result in neovascularization, which can result in forming new points of refluxes and which are much more difficult to treat in these patients. Now, going on to the newer therapies, basically endovenous ablation. This is basically treating the vein from the inside. Now, these are minimally invasive catheter-based techniques. What they do is primarily they tend to achieve endothelial damage by means of thrombosis, fibrosis, and complete eradication of the vessel. Now, endovenous ablation can be divided into thermal, chemical, mechanochemical, or glue. Now, basically, the thermal techniques or non-thermal techniques is a better way of putting it. So, the thermal techniques include the radiofrequency ablation or laser ablation or microwave ablation. And the non-thermal techniques can include either sclerotherapy or Clarivein or Venacil, which includes glue. Now, all these endovenous techniques have been studied extensively, especially the laser ablation as compared to the radiofrequency ablation. And all of them have been found to be equally effective, especially the newer generations of laser, which uses a much higher frequency wavelength of light. And they have enough data to show that all of them have equal efficacy. Now, just a quick note on this thing. So basically how we treat is we identify the GSV segment just below the knee and place a small sheath inside the vein under ultrasound guidance. And this is the radiofrequency catheter that you see, which is passed under the ultrasound guidance all the way to the junction of the saphenous, basically the saphenous vein and the femoral vein. You can see the junction over here, and you can see this is the junction, and you can see the catheter tip. When we place the catheter tip, generally about 2 centimeters away from the junction in order to prevent injury to the deep vein. And you can see over here the vein is being ablated because of the catheter being pulled back after heat energy. You can see a clear phlebatic vein with the catheter being pulled back over here. Now, after treating the primary reflex, we generally tend to resort to foam sclerotherapy for treating the below knee varices. This is basically combining a detergent, which is basically sodium tetradecyl sulfate, and mixing it with air to form foam. Now, what this foaming does is it increases the surface area of contact of the detergent with the vein wall. So, a small amount of sclerostin can be used to treat a large area of vein wall. So, this foaming helps a lot. And you can see over here under ultrasound guidance, the foam is injected. We can see the foam as these bright white areas. Now, generally a combination of these techniques, these are the results that we can see. Preoperatively, you can see a lot of these dilated veins, and postoperatively, you can see none. But you also have to understand that the skin damage takes a long time to heal. And in some cases, it might not go back to, even though the ulcer heals, the skin might not go back to the original color. Depending on the level of disease they have, they might never go back to the original color. Now, just a small word on newer modalities, or basically the non-thermal endovenous. There are a lot of them available. A couple of them which have approval in India include one, this is Clarivein. This is called as MOCA therapy. It's basically mechanochemical ablation, which basically uses a spinning rotor, which tears the inside of the vein while sclerostin is being injected while the catheter is being pulled back. Another popular, which is currently being used quite a bit, is the Venacil closure system. Again, this is a catheter-based closure system which injects a bioabsorbable glue into the vein, which causes closure. Now, the advantages that have been cited for using non-thermal techniques over thermal techniques is the thermal damage to the surrounding tissue is not there. So theoretically, the pain is much lesser and return to activity is much faster. And along with this, Venacil, there is an advantage that they are quoting. There is no need for using compression therapy in these patients post-surgery. That is a being advantage. But personally, I have not seen a clinical advantage of using both of these. Both of them are very good. Now, just results again. Endovenous procedures have less pain, faster return to work, and a low rate of side effects. And a 2011 Cochrane review shows that RFA and EVLTs are as effective as surgery in treatment of great saphenous vein reflux. Now, just summarizing, now varicose veins, modern treatment, endovenous ablation is the treatment of choice. And vein mapping on Duplay first by the primary caregiver is very key to appropriate treatment management plan. And always understand it is very easy to treat the veins the first time. If you treat it right the first time, it makes the job much easier and is a much bigger headache for treating recurrent veins. So always treating the first time, if it comprehensive treatment plan makes your life much easier. Thank you.
Thank you, Vishnu Kumar, for your wonderful presentation. Even though it is a common topic, it will be useful to many practitioners.
Thank you, sir.
Any question from the participants? There are no questions or comments. I thank the speakers of
Excellent,
today.
sir. I think Vishnu did
Yeah, please. Sarvesh, yes.
Vishnu did a wonderful job, sir. Very good presentation. Really, congratulations, sir. And he exposed everything about the varicose veins, sir. Nothing more to add about it, sir.
Okay,
Thank you,
thank
sir.
you. Thank you, Sarvesh.
Thank you, sir.
I thank Dr. Aarti and Dr. Vishnu Kumar for taking part in today's webinar in spite of their schedules. And it's my duty and privilege to thank all the consultants, postgraduates, and doctors, practicing doctors from Coimbatore. And again, next month we'll meet in our next webinar. Thank you.
Thank you, sir.
Thank you, Murli, and your team.